he wants to, but unfortunately he wants to show he had pain, he want to show to the dentist, and finally he started searching for the best dentist he gets, where he will be fearless, he will be taken care fearless, and he'll be treated well by the dentist. So he started searching for a good dentist. So suddenly what happened is he saw a wonderful wonderful post or wonderful board there written like dentistry painless. So he thought, okay, fine. Uh, I can go to the dentist and he'll treat it without pain. So he thought, okay, I'll go and see that dentist. So finally he went in and finally he took the treatment. And when he came out, this is what he wrote: painless dentist LIR. But now actually we can literally practice painless dentistry. That's what I want to say. So now what I am just giving some insights in my lecture, like how we can uh, practice painless dentistry by using certain armamentarium in your practice. So actually, how we see the patient is somewhat like this. Like we'll be, we'll explain to them. So we think that okay, fine, we are well dressed, we are charming, fine. But unfortunately, how the patients see us will be somewhat like this, going with the drill, trying to do something they are not able to visualize. So that anxiety is there. So the anxiety is there. And interestingly, when I was preparing for this, I came across an good evidence on effect of dental anxiety on oral health among first dental visit. So what I came across was, out of the participants, 56 percentage was then anxious, they have dental anxiety. Okay, out of that 80% were having fear for taking injections. So that much of what I want to say is, out of 10 patients we get, more than 6 patients are dentally anxious. So basically there will be a fear. So we won't, I mean, when if we don't take care of the fear properly, that will end up in anxiety. So it's basically a cycle, that fear and anxiety. So what happens is, when the fear intensifies, automatically the anxiety gets intensified. So are we taking, my question is this, are we dealing with this anxiety properly? So we tell them that when we give an injection, we tell them, see, it's not going to hurt, and we assume that the patient is not getting hurt and we'll give an injection. But automatically the patient will have that fear in him, that okay, taking the injections, how it will hurt me, all those things will be there. Fine. So we overthink, or we presume that when the injection what we are giving is not going to hurt them. So, and unfortunately, if you see all the, all the pictures or all the films, they portray dentist as some creature who is giving, some pain to you, or who is giving, some anxiety things. There, you prick, he's getting pain. Or if you see any picture for that matter, a dentist will be picturized as if he's going to hurt you. Fine. So my let me take through you the basic behavior guidance what we do. We all know that. I'm just briefing out. There's something called as non-pharmacological behavior management techniques. There are something called as pharmacological behavior management techniques. So when it comes to the behavior guidance in pediatric as well as adult, I would say adult patients, you are having a different methods, like you talk to the patient, you explain to them. So, but at one point, patient won't be ready to take up the treatment. They are extremely anxious. I would not say that it's only for pediatric patients. For adults also, nowadays they are highly anxious. So that point is there, where we should know how to deal. So imagine you get multiple types of patients, like a patient who's you tell them, they will open the mouth, you're fine, happy. So this is something like, we are the luckiest patients we get. Some patients will be somewhat like this. You will be discussing to them, you will be talking to them, and they'll be crying, but they listen to you, they will listen to you. The third set of patients are somewhat like this. The moment they sit at the chair, they'll start crying. So that is the next set of patients we get. They won't be ready to listen to you what you want to say. They won't be when the moment you take the mouth mirror into in the patient's mouth, they will they will somehow move the mouth mirror. They will show all sides, sorts of tantrums there. And the last kind of patients are somewhat like this. Yeah, they will be stubborn. Whatever you do, I'm not going to open the mouth. So these are the four category patients we get in our day-to-day practice. And I'll be I'll be giving insights on how to manage the patient's anxiety. The some things what you can incorporate in your clinical setup so that the anxiety of the patient is managed properly. So I'll be talking about sedation in dentistry, how safely you can incorporate sedation in your dentistry. And second thing is, in sedation, there are different means of sedation, different methods of sedation. I'll be talking about conscious sedation. In that, I'll be talking about mainly on inhalational sedation, that is nitrous oxide. So this is the thing what we will be discussing in this particular webinar. So basically, when it comes to the sedation, these are the terms we will be talking about. There will be there's something called as mild, moderate, deep, and general anesthesia. These are the sedation terms we generally come across, out of which the sedation what we achieve with nitrous oxide is the moderate sedation, where you will be respond to touch, you will be response to words, the airway is managed properly, breathing is fine, your cardiac activity is functionally normal. So the sedation what we get in nitrous oxide is moderate sedation. So the child will respond. You talk to the child or you talk to the patient, they will respond to you, they will talk to you, everything is fine, but they will be mildly or moderately sedated. The anxiety level will be somewhat less. So this is the changing trends that is coming across. So a little bit into the history. So in when it comes to the history, Joseph Wells is the one who published and researched about the chemical and physiological things. And 1844, Horst Wells tested the use of nitrous oxide for the third model accession. You just see in 1844, the nitrous oxide was being used. And if you see some old series of Charlie Chaplin. This one series itself is, room full of laughing gas, and room. This is again an series of Laurel and Hardy. It's of 1980s and 1990s things. So here also the room full of laughing gas. So here also, if you see, there's a laughing gas cap. So again, it's a medical setup. So at that time itself, nitrous oxide was being used, but after sometimes it was not being properly marketed, or it was not being properly, that safety mechanisms were not there at that time. So they have incorporated everything, and now it has been again coming to as a popular demand in the city. So what is a laughing gas? A laughing gas is a colorless gas. Secondly, it is an odorless. It doesn't have that much of, it doesn't have any smell, and it has a sweet taste. When you inhale, basically you will get some sort of a sweet taste when you inhale. And it has a specific gravity. It has more specific gravity than air, because what I would say is the specific gravity of nitrous oxide is much more than the specific gravity of the air. So when you are using nitrous oxide, the nitrous oxide gas, there is a higher probability that the nitrous oxide gas lays on the just above the floor level because of the higher specific gravity, and it's an insoluble gas. So these are the properties, or these are the things what we should come to know. We should know about laughing gas. So when it comes to the desirable characteristics, why we have chosen nitrous oxide as a sedating agent, so that there are some desirable characteristics that nitrous oxide has. That is why we are choosing nitrous oxide as a sedating agent. So in that, first and foremost is titration. So what happens is you can titrate the gas. Whether you require 10%, you require 20%, you require 30%, you require 35%, all those kinds of titration of the gas is possible with nitrous oxide. Secondly, it is a good analgesic. It has an analgesic effect. So when you are giving nitrous oxide, the pain threshold of the patient reduces. So they won't feel that pain, the pricking pain, and all those things will be less. It's a good anxiolytic. Then it has a rapid cognitive recovery. The moment you give the nitrous oxide and moment you recover or you do the reversal, the entire cognitive recovery is there. The patient is fine. Patient can drive back. They can walk. All those. There is no medical restrictions at all in the with by using nitrous oxide. And third is it's relatively amnestic. When the child is getting sedated, what happens is some things they will forget. They will have a vague idea what you are doing. That's it. So there is a relatively amnestic effect is there, and very very minimal side effects and rapid onset of action. The moment you start giving nitrous oxide, you can see the changes that comes to the child, how the anxiety level of the child reduces. All those things are there. So these are the desirable characteristics of nitrous oxide, and mainly what I would say is the minimal side effects. The with nitrous oxide, the side effects is very 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 minimal. So coming to the objectives, why or where we are supposed to do this. So basically, whenever you are using any sedative measures, basically it reduces or eliminates the anxiety. So the anxiety of the child is reduced, and reduced unto-do movements of and reactions to the dental treatment, because the moment you take some instruments, the patient will get scared. They will move that side. They will try to move their hands and all those things. So that will be reduced. Then enhanced communication and patient cooperation. You are talking, they will listen to you. They will listen to you and they will respond to the commands properly, and raise the pain reaction threshold. The pain reaction threshold is increased, so the chances of the pricking, the needle pricking pain, all those things will be reduced. Then increased tolerance for longer appointments. So when you are sedating the patient, they will be relaxed and lying down on the chair. Even if it takes 1 hour appointments, they won't feel that that much of time they are sitting on the chair. So that tolerance level will be better. Then aids in treatment for mentally or physically disabled or medically compromised patients. So and reduced gagging. Some patients will have a prompt gag reflex. So in such cases, you can give a nitrous oxide sedation because it reduces the gag reflexes and potentiate the effects of sedatives. So these are the objectives. So basically, when you're selecting the major challenge, what happens when you are doing a sedation or nitrous oxide sedation is you should know the selection of the case. When to do, on which patient I'm supposed to do. So when to do is basically mild to moderate anxiety. I won't say that all the cases are you can deal with nitrous oxide or you can do with nitrous oxide. It's not possible. So mild to moderate anxiety patients, a child who is not willing to sit on the chair, child who is not ready to listen what you are trying to tell them, child is throwing that much of tantrums, such patients, it's very difficult to do under nitrous oxide. So I would put it like this: mild to moderate anxiety patients are the good candidates. Secondly, marked gag reflex, I told you before. And for extractions, imagine for orthodontic extractions where the patient is scared, they are not, they don't want to take a injection, the injection prick, they are scared. Such cases, you can go for a nitrous oxide. And secondly, the patients with needle phobia. I would say needle phobia patients, adults are also, nowadays, adults are also highly needle phobic. And where not to, or which are all the patients we are not supposed to go for a nitrous oxide sedation is extremely anxious. As I mentioned, the patient is not ready to sit on the chair. Patient is throwing temper tantrums. Such patients are not good candidates for nitrous oxide sedation. Inability to understand, where the child is too young, 1 year old child, 1.5 year old child, or 2 year old child, you can't do, or intellectual impairment is there. Then marked nasal blockage. The child can't take child can't breathe through the nose, they have to open the mouth and breathe. Such patients, the effectiveness of nitrous oxide will be reduced. So if marked nasal blockage, the effectiveness of the nitrous oxide will be much reduced. So they are not the good candidates for nitrous oxide sedation. Patients with a severe psychiatric disorders, severe depression issues, such patients, it's better take a proper advice from the psychiatrist and then you go ahead with the sedation. Then in first trimester of pregnancy, where it's better to avoid cleft palate and lip patients, claustrophobic again. Most of the patients they might, when they are claustrophobic, what happens is they will take the sedation process will happen. They get sedated, everything is fine. So even when you remove the mask, they will urge to get oxygen. They feel that they are not able to breathe properly. So such issues will be there. So in claustrophobic also, you make the patient little calm and then do the procedure. Then patients with multiple sclerosis. So these are all the cases where we should be a little careful, or they are not the ideal candidates to do the sedation. So when it comes to the ideal candidates, this is a child who is sitting on the chair. You can see the child is sitting on the chair, but he's highly stressed. The body language, if you see, child is with that much of stress, he's sitting on the chair. So this is an ideal case. Secondly, again, this child anxious. You can see the face itself there. That anxiety is there. She's somehow managing to sit on the chair. Again, this is a good ideal candidate. This patient is, which I have showed you before, crying. They are crying fine. She's scared fine. She is also an ideal candidate for a nitrous oxide sedation. So coming to the contraindications where we are not supposed to go for a sedation, nitrous oxide sedation, is severe current upper respiratory tract infections, then recent middle ear disturbance or surgeries which has been done. We are not supposed to do it because that will interfere with the ear balance. Then chronic obstructive pulmonary diseases, severe emotional disturbances or drug related dependencies, first trimester of pregnancies, treatment with bleomycin sulfate, then with vitamin B12 deficiencies. Such cases are contraindicated to do under sedation. So basically, when you are dealing or when you are trying to do a sedation case, just take a brief medical history, whether they are they are under any of these drugs or any of the surgeries which they have done prior. And secondly, the thing is nitrous oxide sedation in presence of increased intraocular, because it increases the intraocular gas, which can cause irreversible blindness. So that is again a contraindication. Then avoid nitrous oxide in immunocompromised patients as it affects the chemotaxis. Then repeated exposure of nitrous oxide may produce leukopenia. So these are the contraindications. I'm just giving a brief idea to you that all the candidates are not a right candidate for nitrous oxide. There are some limitations, some contraindications that is there. So I'm just briefing it out. I'm not making you scared that this much of contraindications are there. Nothing. But you should be a little careful when you're doing it. So when I put it in a nutshell, okay, only patients with ASA class 1 and class 2 should normally be considered suitable for sedation in the primary dental setting. So in our dental clinic, the patients who's coming under ASA class 1 and class 2 are considerably suitable for sedation in the dental setting. And if the patients comes under class 3, ASA class 3 and class 4, it's better to do it under a hospital setup. When you're sedating, it's better you can put it in a hospital setup and do the procedure. So these are the guidelines for the conscious sedation. This is how we are supposed to plan a nitrous oxide sedation case. And again, next, everybody, one major question what I get is, doctor, my child is having asthma, whether he is safe. So nitrous oxide is indicated for asthma because it's a non-irritating. It's not irritating to the mucosa. It doesn't irritate the mucosa at all. It's not an irritant gas. And sedative nature of nitrous oxide has a positive influence on asthmatic patients as anxiety triggers asthma. So the anxiety will get reduced. So anxiety related asthma is again reduced. And if asthma is due to the emotional stress, nitrous oxide works. But nitrous oxide is contraindicated in severe asthmatic patients. That very severe asthmatic patients, it's better to take a consent from the pulmonologist and do the procedure. But mild to moderate cases, we can go ahead with the nitrous oxide sedation. So, what are the advantages? What are the main advantages? What we get is easy to administer, rapid onset of action, which I have already told you. Nitrous oxide is non-irritant, colorless gas, and faint sweet taste. Rapid uptake and elimination of nitrous oxide is that it takes the mode of action is very fast and it's eliminated as fast as possible from the body. And faster recovery and titration is possible. You can titrate it. Wide margin of safety is there. Cardiorespiratory stability is there. Reflex integrity is maintained. Every reflex, you can talk to the patient. You can make, they can lift the hand. They'll respond to your commands. So reflex integrity is totally maintained. No preparation of patients is required and no need for anybody to escort. And the major disadvantage of this is lack of potency. This drug is not highly potent. Then dependent largely on psychological reassurance, then interferes with the nasal hood, because basically there will be a nasal hood. Initially, when you are injecting onto the maxillary region, it will be little difficult. We should get used to that. And patient must be able to breathe through the nose. And nitrous oxide pollution and potential occupational exposure, health hazards is there. So these are the disadvantages we see regarding the nitrous oxide. So before going to the cases, which I show you, there are some myths and realities regarding the sedation is there. The first myth is, I always get this question: can we knock out someone? Or somebody will go to a GA when you give a nitrous oxide, or they will go to deep sedation when you give nitrous oxide. That is the first question. Second question is it a substitute for local anesthesia? Without local anesthesia, can we do the procedure? That is the next question what I get. And regarding the protective reflex, whether they will be fine, whether they get completely sedated, whether they will respond, they will sleep off. So these are the questions I normally get. So what I want to tell you is, so little bit of the pharmacodynamics. Just 2 slides. That's it. It's a nitrous oxide is a less potent of all inhalational general anesthetic medications, and the drug potency is dependent on minimum alveolar concentration. So these are the normal terminologies we see: tidal volume, minute volume, and MAC, that is minimal alveolar concentration. So this is a chart of what I have put, that is MAC values of all the inhalational anesthetics, and you can see in nitrous oxide is 104% MAC value, which means that 104 to 105 percentage, which indicates that at normal atmospheric pressure, nitrous oxide alone is not able to produce surgical anesthesia, which means they cannot take you to general anesthesia level. So that proper surgical anesthesia you won't get. So basically, you will be moderately sedated. Secondly, you require LA, but the pain threshold is reduced. But when you without LA, if you try to do something, they will know. So that surgical anesthesia you won't get in nitrous oxide. So MAC value of 104 percentage is, so it is possible to induce GA below 100%. So since it is 104%, it is not, you cannot induce general anesthesia or surgical anesthesia with nitrous oxide sedation. So coming to the armamentarium part, when it comes to the nitrous oxide, basically this is how the nitrous oxide is mission is there. There is a yoke stand, there is color coded cylinders, there are nasal hoods. Nowadays, aroma based nasal hoods are also available, or aroma paints are also available, where you can paint the nasal hood so that you get that aroma. And there is a flush button. In case of emergency, you can use a flush button, and there are meter readings. These are the common parts of a nitrous oxide sedation unit. So when let me brief out. Okay, so when it comes to the nitrous oxide mission, you have 2 cylinders. Basically, you are having a blue colored collar, which is nitrous oxide cylinder, and white colored collar is a oxygen cylinder. So these are the 2 cylinders you get. That is a generalized one. That is a standardized one everywhere in the world. That is how it is. And nitrous oxide cylinder, which will be blue colored, and when you fill the tank, the pressure at which the nitrous oxide is being pumped out from the cylinder is at the pressure of 750 psi, which again is fixed by the company people. When you buy it, it is prefixed that the pressure at which the nitrous oxide comes out from the cylinder will be at 750 psi. And at oxygen level, oxygen, it is white or black. Ideally, it's a white colored cylinder where there is always an gauge which is there to monitor the oxygen. And in oxygen, it is kept at 2000 psi. So that is the pressure at which the oxygen is being pushed out from the cylinder. And there are some safety features. They ask what are the safety features we have. So there is something called a spin indexing system, and there's something called as diameter indexing systems. So basically, you might have heard that okay, instead of oxygen, they have given nitrous oxide, or some other gas. They child has gone to coma and all those things. But here it doesn't happen. There is something called a safety pin indexing safety mechanism is there. So if you see that there's a configuration changes is there, I'll put a little more closer view. So for oxygen, this is the configuration. The indexing is there. Okay, this is how the index is being configured for oxygen, and this is how the index is being configured for nitrous. So basically, you can't fix an oxygen cylinder on a nitrous oxide slot, or you can't fix a nitrous oxide cylinder onto an oxygen slot. So that is practically impossible to fix a nitrous oxide of cylinder to a. So that is what is called as spin indexing systems. So that is again a safety valve. Second is the diameter. So if you see the diameter of the screws there. So if you see, I can take you to the close-up view. If you see the diameter of the two tubings, it's entirely different. And nowadays the coloring is also there. So blue is for the nitrous and white is for the oxygen. So basically for nitrous, it will be blue color and the diameter will be different. Oxygen, it will be white color and the diameter will be different. So you can't interchange and fix the oxygen tubing to the nitrous oxide slot and nitrous oxide slot to the oxygen slot. So that is called as a diameter indexing. You can see the change in diameter. That much of diameter difference is there for both the tubings. So in short, the safety features are fail-safe mechanism. Imagine suddenly the nitrous oxide, I mean oxygen is finished, the cylinder, when we are in a patient, when we are doing the procedure, suddenly the oxygen cylinder is empty. Suddenly the entire machine cuts. That is a fail-safe mechanism. Then the minimum pressure for the oxygen is 30%, while in ambient air we get only 21% of oxygen. So basically we are giving more purer oxygen to the patient than the pin indexing and the diameter indexing, and you have a oxygen flush. So imagine you feel that a child is getting over sedated, or you don't want you want the child to recover much faster. So you can use an oxygen flush for any emergency. You can press the oxygen flush so that the flow of the oxygen will be increased. And you do have a regulators to see what is the pressure at which the gas has been pushed out through the valve. So this is the regulator what we see in the machine. Fine. So next is the pressure gauge reading. So basically, as I mentioned earlier, for a full cylinder nitrous or full cylinder oxygen, the pressure will be set as 750 psi. Same way, the oxygen, it will be set as 2000 psi. So what happens? I have already mentioned it earlier that nitrous oxide is a compressible gas, liquid gas. So what happens is, till when the nitrous oxide comes up to 50% also, the pressure reading will be showing as 750 psi. And when it goes down, it suddenly dips out. So that is how the pressure reading we see in nitrous oxide. Whereas in oxygen, as long you consume it, so slowly it starts coming down. So that is how the pressure gauge reading is different. So since the specific gravity of the nitrous oxide is higher, and it is a liquefied compressed gas, that is why it takes after 50% only the drop of the nitrous oxide is seen on the pressure gauge. So, but what I would say is when you are using nitrous oxide for sedation, with one cylinder itself, actually you can do around 15 cases aram se without the without much hassle, you can go minimum of 15 to 16 cases without any risk. So next is the heart of the machine. That is a flow meter, which is a very highly calibrated machine, highly calibrated device, which regulates the flow. So basically, we will be regulating the flow of the oxygen as at all. That's it. The nitrous is being, proportionately it will be taken care. We have to just see the flow of the oxygen, whether we are giving a proper flow of oxygen is being given to the patient. Then you have a fail-safe mechanism there, and there are three moving parts. That is the rate of flow. This is the rate of flow. This is how you decide at what flow the oxygen has to flow, and the percentage of mixture gas. So you can see here there is a nitrous oxide that is written there. So that is when you start moving it, it will show that how much percentage of nitrous should be mixed with the gas, and there is an oxygen flush. This is an oxygen flush. You can see one button is there. When you press it, the oxygen will start with a high force, the oxygen will start flowing. So these are the components what we see in the flow meter, in the flow meter. So this is an oxygen flush you can see here, and these are the other components of the flow meters. And basically nowadays when the machine comes, it comes with a reservoir bag. The main advantage of using a reservoir bag is it is an additional source of an additional gas, which is of 3 liters additional. It's just like an artificial lung. Then it visualizes the patient's respiration. You can see whether the patient is respiring properly or not, whether the rhythm is proper or not. That everything can be done, and it provides a positive pressure to the oxygen in case of an emergency. In case of an emergency, you can just pump in the oxygen, what excess amount of oxygen which you have onto the ambu bag. So these are the different types of nasal hood we get. So I would recommend using a scavenger nasal hood, because the advantage of using a scavenging system is it combines the use of a double mask system and scavenging system with a high evacuation flow rate, demonstrates to decrease the occupational exposure to the nitrous oxide. So basically, the exhaled air will move out and it will be taken out. So the exposure to the exhaled nitrous oxide to us will be less when you are using a proper scavenging system mask. So that is about a little bit about the theory part, and now we are just going to come about how it works. So basically, there are certain things which you need to monitor. First thing is you need to monitor about the heart rate. You should see the oxygen saturation. So this you can use a pulse oximeter, and you can monitor these things properly when you are sedating, till you finish the sedation, till the patient recovers. This has to be properly noted. So these are the monitoring things we have to see. So when it comes to the monitoring, we need to see about the consciousness of the patient, the respiration, the pattern of respiration, and you need to step out the saturation. So these are the three things we need to see, or we need to monitor continuously when you are doing a patient under sedation. And next doubt everybody will be having is regarding the pre-procedural fasting guidelines. Whether the child has to fast, whether 6 hours fasting is required or not. So these are the common queries what we get. So ideally, for nitrous oxide, we don't require that. Proper NPO protocols are not required for nitrous oxide. So basically, what I would recommend is, the child should not have had a proper heavy meal, and they should not come for the sedation, because that will interfere with the sedation. Secondly, the proper nap time, where they have a proper, they have proper heavy meal they had and come, then they have fasted and come. All those things are not recommended. Ideally, they can have water, or clear liquids, or any clear liquids, water, fresh fruit juice, or carbonated beverages, clear tea, black coffee. All those things are fine when you are planning a case for a sedation. You can tell that don't have a heavy meal and come. Have a light meal, or with little bit of clear liquids is fine. So now, when it comes to the sedation, how to start with the sedation, you should have a proper consent for the sedation. all the things has to be, this is the consent what I follow in my practice. So everything should be properly mentioned and signed. Local guardian also should sign when you are doing the procedure. Then this is how I introduce the mask, properly keep the mask, make them comfortable. By keeping the mask, they'll hold and keep, and they get accustomed with the mask. Then you start with a timed titration. Don't start, okay, I have kept the mask, start with 50% nitrous. No. Slowly give 10, 20, 30, like that. Incrementally, you start giving the nitrous oxide. So basically, when you are giving a timed titration, the child will be comfortable and it will be in a relaxed state. So slowly when you are starting, when you start injecting, increasing this thing, so the child will get relaxed. They will start, the entire the body. If you see, they will feel more relaxed to the patient. So basically, focus on how you feel than what you feel. So you have to see basically the intense comes from insignificant others. The constant vigil is imperative, as pleasant sensation may quickly become unpleasant. So basically the main indicator is the eye, and major mistake what we do is we'll keep on talking to the patient. So kindly avoid talking to the patient, and you check the eye movements, how the eyes are, how the dilation of the pupil occurs, all those things you see. So this is a patient which when you sedate, you see the eyes are more relaxed. She's not able to open the eyes properly. The eyes are getting ruled. All those things are happening. Say again, the same patient what I've shown before, the way how he was sitting, and just during the sedation you can see he's relaxed, he's smiling. In the first, you can't see, he's not smiling at all. But when you are inducing the mask, he's relaxed, entire body language is changed. So what are the signs of nitrous oxide sedation? So these are the three planes. That is, plane 1 is 10 to 30% of nitrous, plane 2 is 30 to 50% of nitrous, and plane 3 is 50 to 70% of nitrous. So what happens in plane 1? 10 to 30% of nitrous. I won't say that for every patient you will come across with all these symptoms. In 10 to 30% of nitrous, you will be having tingling sensation. The sensation of warmth will be there, and 30 to 50 is the one that is the first plane. 30 is the first plane. So from 30, there are some changes, more visible changes will start happening. That is numbness of the extremities, sensation of floating. They will feel that okay, I am floating on the chair. Auditory changes will be there. They will feel dissociated, analgesia, euphoria. All those things will start coming in 30 to 50%. And most of the patients will get sedated at this level, 30 to 50%. That is the almost around 80% of the patients will get sedated at that level. And 50 to 70% is the time where the child will start daydreaming and laughing and giddiness. They will start giggling, laughing, sweating. Then there will be uncoordinated movement. Then loss of eyelid reflexes. So these are the symptoms you see when you are sedating under nitrous. So this is a child where we have given 30% of nitrous. So if you see, she's not able to hold the hand. That hand is, so that loss of coordination is there. She feels more lighter. And same way, where the pain threshold, what I'm saying is when you are pinching, when you're trying to pinch her, you can see that she's feeling it, but that pain is not there. She's not feeling the pain. She's smiling and sitting. So that pain threshold of the patient is increased. So ideally that level is an ideal time where you can start injecting to the patient. That is an optimal point of sedation, where the patient is more ideally sedated. At that point, if you inject also, they won't feel the prick of the needle. The prick of the needle will be completely, they won't feel at all. And they won't know also. They'll be in a state that, okay, something the doctor is doing in my mouth. That's it. So the same patient, injection has been given. If you see the eyes of the patient, there is no sign of pain. That that she's not trying to close the eyes, or that sign of pain is not there at all. This is again that another child where we are trying to. I mean, we are going to give an injection. So in such case, also when you are injecting, when you are trying to inject, also the when you are pricking, see, he has seen the needle, he's trying to resist, but when you are pricking, he don't have any issue, no sign of pain, nothing. So that is an advantage. That is an advantage what we get when you are doing the procedure. So again, the another child who is very anxious, where she is taking computer controlled anesthesia. I'm giving the injection now. Injection process is happening. She doesn't have any signs of pain at all, or she's not showing any resistance to the injection. This is again nitrous with computer controlled anesthesia. It shows wonder, I would say, because the child is not seeing the needle at all. Child vision of the needle is completely not there, and you are giving it with in a very slow way. That it's been completely controlled by computer controlled system. So when you are injecting, the flow rate of the injection is very slow, so that child will be very comfortable. So he's a child. This guy has been referred to me because he was highly anxious. He has gone to 2 3 clinics, and then he had come to me, and he is sitting. So when you are injecting, this is how the computer controlled anesthesia wand comes with. So when you are injecting, you can see the child is not moving. He doesn't have the sensation of prick at all. So that is the advantage of incorporating a sedation or nitrous oxide sedation in our practice. So this is after the procedure. He is taking a gift from me. That's it. So next question is it only for kids? So this is again a blogger. She had come to me with you can see in her face she's completely pit scared, and with the sedation, okay, you can see she's completely relaxed. She's fine. She's ready to take any treatment. Fine, and she's now started talking. That tension, everything is gone, and now I'm giving injection to her. You can see that she's not that movement, that pain movement or pain resistance, nothing is there. She's perfectly relaxed and taking up the treatment. So that is the wonder what we get. So again, this is a child. Again, she's very scared. Again, nitrous oxide has been introduced to her. Then slowly she's getting comfortable. She's fine. She's getting comfortable to the treatment, and now she's completely relaxed. If you see her body language, how she was and how she was very anxious, now she's completely relaxed, and she's ready to take up the treatment. Now she's opening the mouth. I'm giving a topical LA. She's fine. Doing a root canal. So these are the advantage of incorporating a small sedation in our practice. This is the changes what we get. Now coming to a little bit of adverse effects. The major adverse effect is nausea and vomiting. Okay, that happens when there is a higher incidence of nausea and vomiting is noted where there is a longer administration of nitrous oxide and fluctuant level of nitrous. So what is the fluctuant level of nitrous means? You imagine you have kept it at 30% of nitrous, then suddenly you increase to 50, then you again suddenly come back to 40, then 20, then 40, like that. That sudden fluctuation, if you do, that timed instead of giving a timed titration, you are giving haphazardly, you are titrating the nitrous, then that will induce nausea and vomiting. Then there is a lack of titration. You are not titrating. Suddenly you are giving it 50% and starting the procedure. That will cause an issue. Then increased concentration of nitrous oxide and a heavy meal prior to the procedure. So these are the causes for nausea and vomiting. These are the major issue what we come across. And second problem what we come across will be the diffusion hypoxia. That is when you are reversing from nitrous oxide. What you're supposed to do is you need to keep oxygen for minimum of 3 to 5 minutes, so that whatever nitrous the patient has been ingested or inhaled has to has to come out. So that much of nitrous oxygen should be inhaled by the patient. So instead of that, if they didn't inhale or if you are not giving proper oxygen for reversal, that is when diffusion hypoxia occurs. So basically, when you start the sedation, you need to give 100% oxygen for minimum of 2 minutes. Then you go to 10%, 20%, 30%, 40%, like that. Same way, when you come down from 40 to 30, then 30 to 20, 20 to 10, then 100% oxygen, keep it to minimum 5 minutes. Let them lie down on a chair and inhale 100% oxygen for minimum 5 minutes. Then next biochemical effect of chronic nitrous oxide exposure will be leading to pernicious anemia, because nitrous oxide will lead to the oxidation of B12, vitamin B12, which will reduce the activity of the methionine synthetase, which will impair the DNA synthesis and lead to pernicious anemia. So that is why you should have a proper scavenging system to remove the nitrous oxide from the operator. So the basic dilemma you will come across will be the health and safety issues. So there are a lot of myths that has been spread regarding the consideration. But I would say when you are using nitrous oxide alone, it's relatively safe to use rather than combining with multiple drugs. I won't say that combining with multiple drugs you can't do, but it's fine. But when you are doing exclusively nitrous oxide sedation, the chances of any risk is very less. So coming to the scopes of nitrous oxide sedation, there is a high demand, there is high comfort to the patient, there is high chances of referral, and you have an additional income as well. So let me conclude. Bye bye to the tears and screams and fears. Let's begin an empathetic approach to instill a positive attitude towards fearless dentistry. Thank you. Thank you so much for the patient listening. Thank you so much.
So that was a very amazing session from your part, sir. Now we will open the floor to questions. So if you have any questions regarding today's session, please feel free to ask. Dr. Krishna Kumar will be happy to address them.
Hello, sir. We have one question, sir. Most of us would be vitamin B12 deficient. Do you recommend doing blood tests before procedure?
See, the vitamin B12 deficiency we will get unless and until you are getting exposed to multiple cases. So if you yourself is having a vitamin B12 deficiency, try to get it tested and take a supplement for that. But as such, when the vitamin B12 deficiency you will get unless and until you are getting exposed to that much of nitrous, because you imagine you are doing around 5 to 6 cases a day, you don't have a proper scavenging is there, scavenging is not there. In such cases only the chances of vitamin B12 deficiency induced by nitrous oxide you will get. Otherwise you won't get vitamin B12 deficiency. I just showed because there is a chance of by getting a vitamin B12 deficiency unless and until you don't have a proper scavenging system.
And there is another question, sir, regarding the cost and investments required.
So different companies have different quotations. I'm using Concert. I think it ranges from around 2.9 lakhs to 3.2 lakhs. That is what I feel. That is what, according to my knowledge, the cost range of a sedation unit is. So that is the investment you have. That's a basic preliminary investment you have. But when you start practicing with nitrous oxide in your day-to-day practice, basically, whatever the investment you have put for the machine, you can earn it back.
Then there is another question. It is asked, can I know the percentage how to give NO2 and O2? Like if I give 20% of O2, should I start by titrating the NO2 from 10%?
See, basically, standard machines comes. You are supposed to fix with flow rate of oxygen. Okay, so for kids, the flow rate of the oxygen will be somewhere ranging from 4.5 liters to 5.5 liters. That is the common range you get, and for adults, it will be around 6.5 liters. Okay, so that is 100% of oxygen you are giving. And when you are giving nitrous oxide, so you are not titrating the oxygen at all. Now the oxygen is set, then you are just giving 10% of nitrous. That is auto titrated. You don't need to again see and titrate the oxygen at all. So when you give 10% of nitrous, automatically the oxygen titration happens. The flow rate of the oxygen slowly comes down, and slowly the flow rate of the nitrous is being compensated with the flow rate of the oxygen. So that is how the 10% will be there. Then when it comes to 20%, the same way the flow rate will be adjusted by the machine. That is auto titrated. That's why I'm saying you need to just keep the flow rate of the oxygen. Then you need to start giving the percentage, like 10% of nitrous, 20% of the nitrous. So when you start moving it, automatically the flow rate is being automatically titrated by itself. That is why it's called as an auto titration. So basically, you will be checking the flow rate of oxygen, not the nitrous.
And there are a few more questions. So one have asked your advice on the rapid induction.
See, rapid induction initially don't try because when you get used to the ups and downs of nitrous, then you can start with rapid induction. Because suddenly, when you are trying for a rapid induction, what happens is the patient will suddenly move to the second plane or second level, or the entire body changes will be very rapid. So rapid induction, you can give it for autistic patients or ADHD patients. You can try for rapid induction, but on a day-to-day basis, it's always go for a slow induction, because that is always the child will have a more pleasant feel. But rapid induction, again, if you are confident, you have done multiple cases, then you can go ahead with the rapid induction. But personally, if you ask me, I'll go for slow induction. Then slowly, I'll start increasing the percentage of nitrous.
Then how can we motivate kids and parents for NOIS, and which is the best method for scavenging?
See, best method of scavenging, because nowadays machines comes up with scavenging unit, the scavenging suction. Along with the suction, you get the machine, the company itself provides. So it's easy for you to do the scavenging for the nitrous. Then secondly, the motivation of the child. See, you can ask them whether, how I talk to the patient is, when the child cries, the mother also will feel bad, and all those things are there. So I would say that, the child will be relaxed. I never use sedation in my practice. I always say I'm giving happy gas or laughing gas. So when you always use the term laughing gas, means they will feel okay. Child is getting relaxed, and aram se is lying down. So that is how I try to promote, because the moment you talk the term sedation, they will be in a dilemma. Okay, my child is going to sleep. What happens? The sedation issues, all those things are there. So always I'll put it in more simpler way. I'll just say that it's just a laughing gas you're giving it, and the child will be relaxed, and he won't feel, he won't be scared. The anxiety will be reduced, and he'll be happy to take up the treatment. So when you put it in such a way, it's better that the parent will get convinced for that.
Okay, then we have a few more questions.
Yeah.
Uh, can a BDS graduate do this, and how to get the training?
BDS graduate can do that. There's no issue for that, but you should have a proper, there are some guidelines, some protocols, some trainings are required when you are doing a procedure under sedation. So for BDS graduates, you can do it, but you should get properly trained.
Then can you please elaborate the scavenging system, because my clinic is having compromised cross ventilation.
So that's what I told you prior. If you talk to, I think, Concept, they are having a scavenging unit, scavenging suction as a separate thing, where you can connect your exhaust to that, and there's one more tubing is there, where you can put it. You can connect it to your high volume suction, or you can put the connect it to another tubing where it will get dissolved to the atmospheric air. So that is how nowadays the companies are coming up with the proper sedation, I mean proper scavenging suction unit is also there.
Then adult and early patients, can we do conscious?
Yeah, any adult patients as well as I mean, there is no, that's what, there is no age limitation. The only thing is you need to follow the contraindications what I've told you. You have to ask the patient whether any medical history is there or any drugs they have taken, that's it, but you can do the procedure.
Then it is asked about the vitamin B12 deficiency is common in children, so it's risky to use conscious sedation. How much area does it require in dental operators to keep up the conscious sedation?
See, area, I think once a single unit chair, if you're putting that that area itself, I think 120, 150 square feet is more than enough to incorporate a sedation unit in your setup. Again, vitamin B12 deficiency. When you're taking a medical history, you will be asking the patient whether the child is having a vitamin. They will be telling like whether deficiencies are there or not. So when they are having a you know highly insufficient vitamin deficiency is there, better to consult the pediatrician and then do the procedure. Otherwise, mild to moderate, you can go ahead with the procedure. There's no contraindication for that.
Then advice on patient selection, pre-appointment instructions, and ISPALs a requirement for practicing.
Yeah, regarding the patient selection, I have already told you. I will say that all the patients are not an ideal candidates for I mean for nitrous oxide sedation. Only thing is, you need to stick on to the protocols I have told. Just ask them, take a proper medical history, and do the procedure.
Then maximum time, how much recommend under N2O? Can we do the multiple pulpectomy during N2O?
See, you can go for around 1.5 to 2 hours under nitrous is not an issue. But only thing is when you are giving it for a longer time, it takes more time to reverse the nitrous oxide sedation. So only thing is once you are coming, when the child is coming out from the sedation or when the person is coming out from the sedation, you need to keep more time. Instead of 3 to 5 minutes, 100% oxygen during the reversal, you need to keep around 10 minutes to come out from the proper recovery from the nitrous oxide sedation. That's it. So the maximum of 1.5 to 2 hours you can do the procedure. It's not an issue.
And coming to the last question, why is vitamin B12 contraindicated for sedation?
See, basically, I told you sedation. The synthesis of the vitamin B12 has been hampered when you are inhaling nitrous oxide. So that is what it's not for one or two cases, or when the child is having sedation. Also, when he is taking for 15-20 minutes, it doesn't have an issue. But if the child is taking for a longer time, okay, it's as the previous question, as you said, the child is taking for around around 1 hour or 2 hour or 3 hour procedure. So what happens is there's a chance of the synthesis of the vitamin B12 is being hampered. So there's a chance that the child will have so the vitamin B12 will drop more, and the child will feel more uncomfortable. So that is the reason why it's better to avoid when the child is having a vitamin B12 deficiency.
So I think there is no more question left in the chat box to answer. If any more questions, you can ask, and the chat box is still open for you all. And I guess we have come to the end of the Q&A session. So once again, on behalf of Online Dentistry, I sincerely thank Dr. Professor Krishna Kumar sir for his wonderful and insightful session. Your expertise and valuable guidance have truly enriched us with this session. So thank you all. Thank you all participants for joining us, and have a grateful evening. Thank you.
So thank you and good night all.